Welcome to Utilizing Science, Technology, and the Arts to Transform Pain, an update. We're glad you're here. My name is Angie Hunt, Project Manager with the Canadian Institute for the Relief of Pain and Disability, and I'll be moderating the webinar today. This webinar is made possible through the support of the Community Gaming Grant Program through the BC Government, as well as donations and memberships to CIRPD. We thank our program partners, Pain BC, Education Advisory Committee, and speakers who contribute to this webinar series. While we're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing and to ask any questions you have related to the presentation. We will collect questions submitted throughout the presentation and follow the presentation with a Q&A based on the questions submitted. Following the webinar, any questions not answered in the allotted time will be answered and distributed after the event. The presentation will be recorded and posted for free on our website within a week, along with the slides. You'll be emailed the direct links for all of these items when they are available. As I mentioned, my name is Angie, and I'll be moderating the webinar and Q&A session. Our presenter today is Dr. Diane Gromala. Dr. Gromala is a Canada Research Chair in Computational Technologies for Transforming Pain and a professor at Simon Fraser University. As the founding director of SFU's Chronic Pain Research Institute, she brings together interdisciplinary teams of physicians, neuroscientists, computer scientists, media artists and designers, and industry experts who are investigating how new technologies can be developed to address the many facets of chronic pain. Dr. Gromala pioneered the use of virtual reality to manage chronic pain and has incorporated VR into diverse health technology systems for patients and health providers who struggle to manage complex chronic conditions. Her work is rigorously tested in clinics and hospitals. Because Dr. Gromala is concerned with making this technology accessible, she is now testing it in patients' homes. This research is supported by CIHR, Canadian Institutes of Health Research, the Natural Sciences and Engineering Research Council of Canada, the National Science Foundation, and the National Institutes of Health. And now I'll hand it over to Diane.
Hi everyone, thank you so much for taking the time to attend the webinar. So I'm going to first introduce myself and just let you know a little bit more about me. I'm a professor and researcher, and I have no conflicts of interest, so none of my work is funded by big pharma or industry, and I don't really gain any profit from it, except for helping people, I hope. I'm also the founding director of the Pain Studies Lab, where most of my work takes place, and the Chronic Pain Research Institute. This is a slide to give you a sense of the number of people who are involved and the kinds of people. So we have experts from medicine, science and engineering, and art and design. And that kind of makes us a bit unique because usually the focus is on one of those three areas. So in my lab, we have healthcare experts, scientists, and artists, and we work together to create technologies that are useful to real people who have long-term chronic problems with complex pain. And this is to give you a sense of what goes on in the lab and who we look like. When I meet people and I tell them that I have chronic pain and I've had it for decades, I inevitably hear, and probably you do too, "Have you tried?" And then they list one of these things. I hope you're laughing. Now, of course, they mean well, but if anyone has chronic pain, you know you'll try just about anything. And that's one of the things that concerns me with my work is I'm probably more cautious than I need to be, but I'm really concerned that none of this is snake oil because I've seen and experienced some of that myself. So I know that just managing chronic pain can be overwhelming, especially in our healthcare systems because they were never designed to cope with long-term ongoing conditions. So my question is, what kinds of non-invasive technologies can we develop that will help? So in today's webinar, I'm going to talk about three things. First, immersive virtual reality for acute pain and chronic pain. Two, how technologies like VR are affecting and changing how pain is managed, both by doctors but also by patients increasingly, and the idea of the quantified self, which I'll define in a minute, how patients and doctors communicate. And in the research and development, things have really changed from having experts to really including patients as collaborators as health research becomes more patient-centered. And finally, I'll end with what I hope are useful guidelines for non-experts, so you can have a better sense to assess whether any technology claims have merit or not. So to begin with, let me just quickly go over chronic pain, the disease. I'm sure most of you are well aware of this, but first, we don't know what causes it. There are lots of indicators, but no one's sure yet. And two, we don't have a cure yet. So it seems to be more about managing what we can. And when we refer to rehabilitation, what we're really talking about is getting to a point where it's the best you can possibly be given the circumstances and sustaining that. So chronic pain is really complex because there are related conditions that are also called sequelae, such as the ones listed here, depression, anxiety, and so forth. The ones that are listed in bold are the ones that my lab and I address. So because chronic pain is complex, I think it's really important to understand that multiple or multifaceted approaches are necessary. So I hope you're not listening to this hoping that it's the one thing that will, cure your pain, because usually it's not one thing, but it's more a combination of things, from medications to managing to get to sleep better, to eat better, and so forth. But there are a lot of things that we know that help, and so I'll talk about those. The first is what I do, which is immersive virtual reality. If you're not familiar with this technology, it looks like this. There are two main versions. One with head-mounted displays, so these are 3D goggles you wear. And the second one is more of an environment or a space where the walls have 3D projections. And it was initially developed following World War II for training, where the costs of mistakes were really high in terms of human life and or machines. So here you see some of the founders. And it was initially developed for fighter pilots. So how is virtual reality different from any other kind of technology like 3D video games? In VR, you feel like you're actually inside the simulation and you're not merely looking at it on a computer screen. And it responds to you, which enhances that sense that you're really inside a different space or are immersed in it. And there are a number of ways that the computer knows what you're doing in real life. And that can be through keyboards or game controllers, joysticks, or sensors that are embedded in gloves, bodysuits, new brain-computer interfaces, and treadmills. This is to give you a sense of different kinds of input devices. It could include your head, your hands, your voice, your feet, or your whole body. And one thing to really remember is that VR isn't new. So virtual reality was a popular idea in the 1990s. But as Brenda Laurel says, never promise what you can't deliver by Christmas. So it really stalled in around the year 2000 because we couldn't deliver the hardware and the software. And this was, remember, before smart cell phones, before iPads, before many people had email or were using the web. So a lot of kind of promise of what technology could do for us was really focused on virtual reality. But when it couldn't deliver, people lost interest. But then what happened in the meantime is the hardware and software was developed. And so it regained momentum in around the year 2014. And that's when Oculus Rift was sold to Facebook for $2 billion. Let me say that again, $2 billion. And since then it's been growing again. There's kind of a new wave of interest in it. And the consumer VR market is estimated to be around $5.2 billion by the year 2018. So we think that this time it's a much better bet that virtual reality will actually be used and be accessible to consumers. For healthcare, since the early days in the 90s, virtual reality was really seen as a really interesting area for healthcare because, like training fighter pilots, it's good for training surgeons to practice before they actually cut into flesh, particularly with surgeries that are really complex. Also, it was and is great for rehabilitation following stroke, where exercises can often be really boring, especially if you need to do it for months and months or years. And it's also excellent for anxiety disorders, phobias, increasingly for post-traumatic stress disorder, schizophrenia, Parkinson's disease, and for our purposes, acute pain and phantom limb pain. And that's just to name a few. So healthcare is really one of the main application areas for virtual reality. The other one is games. In the year 2000, researchers at the University of Washington, where I was at the time, started looking at immersive virtual reality for pain because we thought it could be a great method of pain distraction. So Hunter Hoffman pioneered this for acute pain and for procedures that were short in time, such as changing bandages for burn patients, which is what you see here. And he conducted a number of small but important studies during 2000 to the present. This is an example of Snow World on the right. So what the patient is seeing through this device he's looking into is this cold world where he follows a river through an ice cave, and there are penguins he can throw snowballs at and different animals and so forth. For those of you who are interested in statistics and research results, you could look at this later, but this is an example of his findings, which were really interesting because for the first time, not only did we have evidence that virtual reality could reduce pain in the short term, but that it reduced the amount of opioids or analgesics, painkillers, that were required by patients during very painful procedures, like changing bandages for burn patients. And with the opioid epidemic, I think that's a really important finding. And he verified that in a number of ways, including brain scans. So the question is, okay, how does VR actually work as a painkiller, as a non-pharmacological analgesic? We don't really know for sure. When I first started working with health researchers and they said evidence-based research, I thought, what are they talking about? Of course we have evidence for all of our research, don't we? And it turns out that in healthcare, some of the things we take for granted, that everything has been studied, isn't actually true. And to give you a historical example, doctors used aspirin for hundreds of years before they figured out how it actually works. So that was surprising for me. But increasingly, everything has to be studied and verified. Nevertheless, we're not sure in this case, because it's so new, how VR actually works. But we think there are a number of theories that could explain it. One is that it captures so much of patient's sensory and perceptual abilities that it really focuses attention, and your brain simply doesn't have enough capacity to attend to everything. So pain is relegated to the background of your attention, and the VR world is at the forefront of your attention. Another theory says that it affects, and we have proof of this, one or more of the 5 brain areas that are associated with pain. Another theory suggests that it may modulate pain in really interesting ways. This is the gate control theory, where as the pain signals go to your brain and come back down from your brain, they can be affected by many things, including your mood, your environment, your social milieu, and VR could be one of the ways that it gates or changes the way pain is processed. And finally, there's a theory that says your brain can change. I'm sure you've heard a lot of that lately. The term is called neuroplasticity. So researchers used to claim that the brain didn't change, that once you were an adult, your brain was more or less fixed. But we know now that, of course, the brain does change. In easy to see way that it changes as we constantly learn throughout our lives. But it can change in more fundamental physical ways as well. So virtual reality has been studied for the last 17 years for acute pain. I'm one of the first researchers to look at VR for chronic pain, and that's a much bigger challenge, I think, because we're talking about long-term, highly resistant kinds of pain, and how one manages that, because a cure isn't ready for us yet. So there are 2 paradigms for building virtual reality for chronic pain. One is the more, let's call it, traditional approach, and that is pain distraction. And that's the paradigm that the acute pain virtual reality systems were built on. And again, the idea is that the virtual reality is so immersive that it distracts one from one's pain. And that's limited because it's only effective while you're wearing the virtual environment. So the other paradigm is one that I've developed. And the idea with this paradigm, which I call self-modulation, is that VR is really good for training people and for retraining one's perception and sensorial responses. And so VR could be useful for long-term pain as a training mechanism. And my idea is that if it's really successful, you won't need VR forever, just for training purposes. And then over time, you won't need it as much. So I hope that my research is a bit like dentistry, where the more often you go to your dentist, the less often you need to see them. My first work here for chronic pain was in 2002 with a meditation chamber, and we studied 411 people. In research, we're called human subjects, not people. I have references at the bottom of my slides if anyone wants to look up some of these papers. So I'll give you an example. I was going to originally show lots of different kinds of technologies, but when I looked at this again, I thought going a little deeper into fewer, I think, is more instructive and kind of explains things better. So one of the VR systems I developed for chronic pain is called the Virtual Meditative Walk, and it's an immersive virtual reality system that is combined with biofeedback, and it's meant to teach mindfulness-based stress reduction which is also referred to as MBSR. I chose MBSR because it's been studied for the last 30 years, and it's been recommended by pain experts as one of the best methods to self-manage one's pain. The idea here is that we know that chronic pain is akin to our pain response system being hypervigilant or hyperactive. And so the more we can reduce our stress and calm down that system, the less quickly our pain can change and increase. So what you see, this would be 3D, and you can move your head and things. It wouldn't be static like this image, is a virtual forest that you walk through. And when you're changing your biofeedback, as you hear the vocal coach asking you to breathe in certain ways and pay attention to your breathing and things like that, the more you reduce your stress, the more the fog clears up. And that happens in real time or moment by moment. Now, we don't need technology to learn mindfulness-based stress reduction. But what I found from a lot of studies is that the one thing VR does provide is real-time feedback. And so for many, many users, sorry, I'm a geek. I refer to patients as users sometimes, I'm sorry. But for many, many patients, the real-time feedback is crucial because it takes the mystery out of meditation and trying to affect things like your heart rate, your breathing, the way your skin responds to electricity and so forth, which is an indicator of your mood and emotional state. And in this case, you don't see a graph, which is more typical in biofeedback. Rather, the environment itself changes. The fog clears up, the sound changes, the clouds go away, the sun rises, and so forth. Here is a short video.
In which users will learn a walking form of meditation. Data from the physiological sensors attached to your body will modulate certain aspects of the environment. Your general level of arousal can affect this environment.
So that's a quick example of what you'd see and hear. So for the past 7 years, I've been studying the virtual meditative walk among chronic pain patients. And I've been really closely documenting and incorporating the very specific needs I found of chronic pain patients in our VR systems. So I think that's our special sauce, as it were, because these things are really hard to build. They're a bit like trying to create an indie Hollywood movie. It takes a lot of time and a lot of expertise. So there's not a lot of time really left for figuring out what's necessary for specific groups of people like chronic pain patients. But that's really what my research is focused on. And in our studies, this VR system consistently provides chronic pain patients with some levels of pain relief. And that varies, but there are a few people that this doesn't provide some level of pain relief for. So that's really, really promising. And we're into hundreds of patients who have used this by now. And these studies have also shown us that regular practice is really key to the long-term effectiveness. So over time, as VR and non-VR research has shown, it's the regular practice that helps dampen the pain response system and increases pain tolerance. So in effect, you have or feel less pain, and it's less bothersome. So now that we know that the virtual meditative walk works, the next step is to make this accessible to doctors and patients, clinics and hospitals. So that's what I'm working on at the moment. And again, if you're interested in my research papers, I have the URL for where you can find those at the end of this talk. But more importantly, these and our many other studies really demonstrate something that's really important. And if you take nothing else away from the webinar, I want you to know that you can't go to a store and buy off-the-shelf VR goggles, which you could today at Best Buy, and VR games, which you could get in from a company called Steam. And those two things together, although you can buy them, they don't automatically provide pain relief. It's the design of the virtual environments that is really crucial here. And I put my money where my mouth is, so I say that based on the many studies I've done. But I also team up with other researchers to make sure that I'm not just biased. Because I've created this. So currently I'm conducting studies with 2 other health researchers among cancer survivors who have chronic pain, and they're using this VR in their homes for 6 weeks. And it's a combination of off-the-shelf VR games and the virtual meditative walk. So this should verify what I've been claiming, but I make sure in every case for every virtual environment I create that it actually works, not only from my studies, but from other people who use it in research studies. And this is an example of the so-called phenomena that's called the quantified self. And in this phenomena, it refers to a growing number of people who are interested in tracking their personal data. And that could be anything from wearing a Fitbit device that tracks your physical activity and visualizes it and displays it on the web for you, kind of day by day and month by month. But it can also be other kinds of personal data, such as what you eat, your blood pressure, your blood sugar levels, and things like that. But taken together and tracking the many different aspects of our life is referred to as the quantified self. So the virtual meditative walk, initially I was designing standalone VR environments, but increasingly I found that to be really effective, I needed, of course, to take the larger context of a patient's life into account. And so that includes providing doctors, clinics, and hospitals with my VR, and then also developing ways for people to use it in their homes or at work. So in this case, for the virtual meditative walk, this VR plus biofeedback system provides mindfulness-based stress reduction training so that patients can better manage and decrease their pain. But regular practice is key. And the one thing we know about technologies like VR or social media is that they help daily practices that can otherwise be boring or that people aren't really good at adhering to. And so the second phase of this development is that we've developed apps or applications that patients can use on their computers at home, on their smartphones, or their tablets and iPads. The advantage here is that sorry. The advantage here is that these apps that are in patients' homes provides a way for them to track not only the information they get from using the virtual reality environment, but their pain levels, what they eat, and that sort of thing, so they can start to find connections between things they do and how it might affect their pain. But I think also, at least in a personal sense, I know that when I try to become more physically active or eat better, if I can actually see some benefit in some way, if I can see the visualization that, you know, I feel better and look, I've been more active over the last 2 months, that makes a difference, at least for me and for many of the patients that are in our studies. So the big research question is, we know that the virtual meditative walk works, but how does it work? How do we explain it? My hypothesis is that the VR combined with the biofeedback enhances learning mindfulness-based stress reduction, because the feedback lets you know that you're actually affecting physical change, that your physiological states that otherwise seem hard to get at, like your heart rate, you can actually change intentionally, and you see the change as it happens, and that's referred to as in real time or moment by moment. And I think it may work because it engages and it reorders perceptual and sensory kinds of qualities in really tight feedback loops. And over time, I think the really interesting aspect is that neuroplastic or brain changes may result, and one's pain threshold may rise. So when your pain threshold rises, the level at which pain is bothersome and interferes with your life is reduced. I have a really interesting current unexplainable finding, and that is when I was investigating more accessible, less expensive forms of VR, which are called mobile VR or cardboard VR, among chronic pain patients, I expected to find a very big difference between the traditional head-mounted displays or the kind of VR goggles you wear and these, you know, really inexpensive forms, and I didn't. I didn't find much difference at all. It was negligible. So this is what the so-called cardboard VR device looks like. We're designing a more comfortable version, but it's actually cardboard that you fold up together. It has a little optical lens that you insert in it, and you put your smartphone in it. Your smartphone becomes and can display stereoscopic images, which are created through this passive optical unit. So this becomes a really inexpensive form of virtual reality. And this was the graduate student who worked on it. He's from Bangladesh, and he wanted to look at much more or much cheaper versions of VR. And so our findings were really, really interesting. And I'm going to build on them. Where we are now is, since I've last spoken to you, we've finished our pilot studies, all of our usability studies, and our clinical studies, where users have 6 sessions in the virtual meditative walk in a clinical environment, and then they can use home-based or work-based apps on their home computers or work computers or smartphones or iPads. And as VR becomes less expensive, we're creating more and more systems that people can use in their homes. It's important to note that this change is coming really, really quickly. So in the year 2014, a head-mounted display was $40,000. A year later, it was $350. The cardboard VR I was referring to is $25. Of course, it requires that you have a smartphone, nonetheless. Things are changing technically very quickly. So the other immersive virtual reality environments I'm designing and studying in my research lab are VR pain distraction. And as I said, this is a short-term method for pain relief. But I decided not to actually throw this baby out with the bathwater because I thought it would be useful for breakthrough pain that is fairly common among chronic pain patients, or for temporary relief of arthritis pain, and for other kinds of pain that are shorter term, such as for chemotherapy procedures. And we have a number of virtual reality environments for chemotherapy among teenagers. Our real focus is on VR for pain self-modulation, for really the harder long-term chronic pain patients and the kind of complexity and sequelae that come with chronic pain. And of course the mobile or cardboard VR. We also create VR for cancer survivors who have chronic pain and are using VR in their homes over 6 to 8 weeks. And finally, the newer areas we're looking at is empathy training for health professionals and for addiction recovery. The idea for the addiction recovery is that for residential programs, patients there recover usually very in stable ways, but as soon as they re-enter real life, it becomes a challenge and there are triggers that may lead to relapse. So the idea is to use VR and recreate some of the triggers so that these patients can try to find coping mechanisms for those triggers before they re-enter real life. This is an example of the empathy training for health professionals. So one of my graduate students, actually 3 of them, developed this virtual environment as a way to show the public or give the public a really embodied sense of what it's like to have chronic pain. That may sound crazy, but actually it was interestingly effective. The way this works is that there's a sensor that tells the computer how you move in real unconstrained space, so you don't have cables connected to you. And as you move, the person here, the avatar, moves. And the way that avatar moves is limited as if the avatar has chronic pain. So let me play a quick video to show you what that looks like. So basically for this, you inhabit this avatar of a grandmother who has chronic pain. Looks like a young grandmother to me, but there you go. And when we showed it, our research results at pain conferences, we had a number of health professionals who came up to us and said, you know, we really need that. We really need doctors and nurses to get a better sense of what it's like to be in a body that has limitations from pain. Next, the focus of my lab is to create things to help people with long-term chronic pain, and that includes arthritis and increasingly problems with aging, because most people who are over 60 have some degree of pain, and for addiction recovery. and as I said, empathy training for health professionals. And what's really different about our research is that it's in the vanguard of health research that has started to include patients at every stage of development. Not one patient, but many patients. And that's not a typical practice. It is in computer science, but not so much in health research. The focus has grown in my lab from looking at VR as standalone environments to VR for really specific contexts, and VR as part of a larger chronic pain system that includes enabling patients to track their personal data and to communicate with their doctor and show their doctor the data that they've been tracking. Now, one thing that we've found very early is that most doctors just don't have time to really look at pages and pages of patient data. Even if you're keeping really great records and you're finding that, you know, when you don't sleep for a week, this happens, or when you have been eating that thing, you know, your pain gets worse, or correlations like that. Doctors just don't have time to process that. But when we show them the data in really easy to read visualizations, they do have time. So it's the visualization part that's really key here to the patient-doctor communication and relationship. And I think it also provides, there's kind of new avenues where imagine using Skype and interacting with a doctor or other health professional so that you don't go to your pain doctor, you know, once every 3 months, but it can be more frequent than that. It could be chronic, right? Kind of paralleling your everyday needs. And so that social media component, I think, provides some really pioneering, really interesting ways to extend healthcare. And doctors are actually excited about that. So that's great. And finally, our work has become that of advocacy too. So, for example, I was part of a Canada-wide research network of technologists, and almost no computer scientist had heard of chronic pain, certainly not chronic pain research. And so over 5 years, at least 250 professionals learned what chronic pain was. And I see that as a form of advocacy. I also give talks for nonprofits and so forth, but in the professional realm, I think it's really important that more and more people understand the complexity of this disease and how many thousands and millions of people it affects. So I'm going to end here with trying to provide you with at least a first step in trying to determine whether any claims from technologists have value, because as I said, in the technology world, it's built on making claims to be first, making claims to work. And when people in industry, and I speak as someone who worked in industry for a decade at Apple Computer back in the 80s, I know that what counts as research in industry is not the same as research in academia. So I've come up with 3 guidelines, and on my website next month I have a much more in-depth approach, but for now I think these work. How can you tell if it's just snake oil? And I have to tell you, there's a lot of snake oil out there. I attend many national and international pain conferences, and at these conferences there are exhibitors from industry. There are many different kinds of devices out there. There are many kinds of claims out there, and it scares the hell out of me, I have to say. So I think it's really important that you have a way of trying to figure out, does this work or not? The first thing, and I know this seems self-evident, but let me just say it again. do the claims seem too good to be true? If the technology or system claims to, cure 17 different kinds of chronic pain and chemical sensitivity and things like that, it's probably not true. Now, there might be parts of it, like eating better, that may help, but if it seems like, you have to join something, and if you, buy, 5 CDs, then you become a member at a higher level, and that enables you access to more information. I would be very careful about websites like that, and there are a lot of them that claim too much. When they do claim a lot, look for evidence. And evidence is a tricky thing because, as I said, what industry considers research could be, and you see this for cosmetics all the time, 88% of women said their skin felt softer after 8 weeks. Well, they funded that research, so that wouldn't count as university research. It doesn't have to be research in a university, but if it is in a university, it's a really good bet that it's been vetted. For example, everything I do has to pass really rigorous ethics approvals, and every step of the way, people are looking, people are checking, they're making sure that the claims are accurate and that sort of thing. It could be a third party who's not connected in any way who can provide evidence that the claim works, but for university research, you can be sure. I provide an example here. So a research paper looks something like this. You'll see authors' names, dates, titles from a conference proceeding or journal, and page numbers. The abstract tells you what the study was about. The subjective measures, you don't really, it's great if you know what this stuff means. Most people don't, and that's okay. But you're looking at ways of measuring things. If you really want to be sure, you could bring that research paper to your doctor or another expert. But if you see something that looks like this, the bet's pretty good, and especially if there's research from more than one university group, that's much better evidence. And finally, do any of the research papers appear in Pubmed? So Pubmed is an online database of research papers. One of the problems in multidisciplinary research is, for example, computer scientists like me, we publish in very different journals than health researchers. And so when they go to Pubmed, which is their database, they don't see any of our work, and vice versa. So computer scientists don't always look in Pubmed. So getting those two communities to talk to each other is difficult. But by the time it reaches Pubmed, you can be pretty certain that the thing works, because there are hundreds of people who've looked at it by then. Okay, so in today's webinar, hopefully you've learned a bit about immersive virtual reality for acute, chronic, and cancer pain, but mostly chronic pain, how technologies such as VR are affecting things like they provide a way for you to self-manage your pain. The way we're designing them are an example of the quantified self. It can increase doctor-patient communication, and the research and development has changed to include patients more often at many levels of development. And I hope those guidelines are useful. If you'd like to look at my research papers, you can visit my website, and I have papers from the last 3 years there, or you could go to Pubmed. And thank you so much for your time and interest. If you're interested in becoming a test subject in one of my studies, you can contact me and I think the CIRPD. Over to you, Angie.
Thank you, Diane. We have time to ask a few questions from our audience. Audience members, if you have any questions, please enter your questions into the question box on the GoToWebinar panel. One question that came through: are we talking about neuroplasticity when we talk about the effects of virtual reality?
I think we are. Again, I always get criticized for being too cautious, but I feel a responsibility. I think it is an example of neuroplasticity, but it's always a question of degree. I think neuroplastic changes require, we know, at least 20 minutes of time, and things like mindfulness-based stress reduction, where you practice it every day or several times a week for longer than 20 minutes, I think there's definitely neuroplastic changes. There's research that shows that very clearly. For mindfulness-based stress reduction. For VR, it's early days, and it's hard to get VR equipment into an MRI machine. But I think that that's being addressed, and we'll see those studies I'd say in the next year.
Okay. Has VR ever been tested with patients who suffer from pain associated with sickle cell anemia?
Yes. There have been a few studies since, I think they began in 1999, but yes, there have been. I haven't seen any recently, but I bet that interest in that area would be invigorated, because I know that my colleagues are definitely interested in those areas, yes.
Another question: when will the virtual meditative walk be available to the public?
That's a great question. I'm really struggling to make it accessible by the end of the year. I'm not sure I can. I've looked at the commercialization route. It looks to me like licensing it will be easier. I'm trying to get it to be accessible for free. That surprisingly is more of a challenge than licensing it and selling it for something like $25. But I hope by the end of the year, if not pretty soon thereafter. And I'll have that on my website as soon as it's available.
Okay. And we can also include your website in our resources for our audience as well.
That'd be great. Thank you.
I think that concludes the questions. Oh, one more. Have you been able to quantify the difference between acute versus chronic pain?
That's a really interesting question. Let me tell you why. Pain researchers typically have a biopsychosocial approach to research, and that means that there's quantitative and qualitative approaches. Pain's notoriously difficult to quantify, and pain experts, when I first entered the arena decades ago, I was surprised that quantification wasn't kind of reliant on patients, but it is, and I think that's really interesting. Partially that's because there are no biomarkers that we know of and are sure of that indicate pain. Other diseases like diabetes have that. Health research kind of depends on that, but for pain, it's trickier. It's also trickier because emotions modulate pain and are a really important aspect of the way pain is processed. So yes, the difference between acute and chronic pain is quantified and has been quantified. However, it's important to know, I think, that it's qualified by patient self-reports. The difference between acute and chronic pain, as it's defined by the International Association for the Study of Pain, is that chronic pain begins at 6 months. I say a year just to be super cautious, but they say lasts for 6 months or longer and has basically affects a person's life in negative ways. Where acute pain is the kind of regular pain that we're all more familiar with. Something happens like an injury or disease, it causes pain, you heal, the pain goes away. That's acute pain. Chronic pain persists. Sometimes we know why, often we don't.
Okay, I think that concludes our question and answering session for today. Dr. Gromala, is there anything you'd like to add?
No, I just thank the attendees and I hope everyone feels better soon.
Thank you very much for your presentation.